Hello all, welcome back. So now we will continue with the yesterday's discussion. Okay. So without wasting much time, we'll move into the next question. So here we have a 58-year-old man with type 2 diabetes mellitus, and he is receiving a oral drug therapy. He has developed some mycosis, onychomycosis, and he has started on ketoconazole. Soon after, increased plasma levels of his anti-diabetic drug are noted. So what is happening? He has received some oral drug for diabetes, and then he was given a drug which is ketoconazole. And now what is happening? The levels of this drug, it has increased. So they are asking which DPP4 inhibitor is most likely responsible. They're asking what drug is this oral diabetic drug. So if we look at the options, all the drugs which they have given are DPP4 inhibitors. So what is DPP4 going to do? It is going to increase the GLP and the GIP, and therefore it is going to increase the insulin secretion in the body. But what is happening here? So yesterday we saw about drug inducers and drug inhibitors, right? Some drug act as inducers. It induces some enzymes, whereas some drug it acts as inhibitors. So yesterday I was telling you, you either remember an inducer or you remember the inhibitors. So yesterday I told you a mnemonic for remembering the inducer. If you remember, it is GPRS cell phone. Okay, I said G for griseofulvin, P for phenytoin, R for rifampicin, S for smoking, and C for carbamazepine. This and P for phenobarbital. This is what we learned. And what is the extra thing we learned? We learned that all the anti-epileptics are inducers, except there is only one inhibitor, which is valproate. And we also saw all antibiotics as well as antimicrobials are inhibitors, except rifampicin and griseofulvin. So here, what is a drug? It is ketoconazole. This ketoconazole, is it coming under this group of drug? No. So what it is most likely to be? It is going to be an inhibitor. So what it is going to do? It is going to inhibit this enzyme. So when this oral diabetic drug is metabolized to an inactive product with the help of some cytochrome enzyme, and this ketoconazole is going to inhibit this enzyme. So what is the meaning? Among this whole list of gliptins, there is going to be only one gliptin which is metabolized by some cytochrome P450 enzymes. So what is that gliptin? As you can see, there is only saxagliptin which is metabolized by the CYP3A metabolism. The rest all gliptins, it is, for example, sitagliptin, it undergoes renal excretion, and linagliptin biliary, and vildagliptin, it undergoes hydrolysis. So what is the answer here? The answer here is saxagliptin. So saxagliptin is a drug which gets metabolized by the cytochrome enzyme, and that is the reason why its levels are increased in the blood. So now moving into the next question. A 62-year-old man with diabetic kidney disease, and he also has heart failure, and he has initiated on finerenone therapy. Which of the following statements regarding finerenone is false? So what is finerenone? Finerenone is a mineralocorticoid receptor antagonist. So we already saw how this finerenone works, right? So yesterday, what did we see? This spironolactone, finerenone, eplerenone, all these are mineralocorticoid receptor antagonists. So it goes and binds to the mineralocorticoid receptor and it gets translocated to the nucleus. Once it gets translocated to the nucleus, what happens? It prevents the protein synthesis. It inhibits the protein synthesis. So what is it synthesizing? It is synthesizing a channel which is called as ENAC, epithelial sodial channel. And what is this epithelium sodium channel is doing? Normally, the epithelial sodium channel is responsible for the reabsorption of sodium, and it is also responsible for the excretion of the potassium. So since this channel is not secreted, what will happen? Sodium will go into the lumen and therefore it will get excreted. And what will happen to potassium? Potassium will be preserved. It comes back to the cell and then to the blood. This is what is happening with the eplerenone. Now, is there any differences between the three mineralocorticoid receptor antagonists? Yes. So spironolactone, eplerenone, and phenrenone, all three are mineralocorticoid receptor antagonists as we saw. But what is the type? For example, spironolactone is a steroidal. It is a steroidal type. And this also comes under that. The only non-steroidal is phenrenone. And receptor selectivity, spironolactone is non-selective receptor selectivity, whereas these two are selective. But the anti-androgenic effects, since it is non-selective, the anti-androgenic effects are more with the spironolactone, and hence the gynecomastia is also more with spironolactone, which is absent with the other two, which is eplerenone and phenrenone. And what about hyperkalemia? Spironolactone has increased tendency to cause hyperkalemia, which is decreased with the other two, which is eplerenone and phenrenone. And what is the main use? As we know, this mineralocorticoid receptor antagonist, it forms a very important use in congestive heart failure. It is going to prevent the remodeling of the heart. In addition, spironolactone, since it decreases the androgen level, it can also be used in hyperandrogenism. This is an additional use of spironolactone. And what about the BP lowering effect? The BP lowering effect is also more for spironolactone, and it decreases, and it is very less for phenrenone. And cardioprotection, it is offered more by phenrenone, and it is offered moderate to a moderate degree by spironolactone and eplerenone. And the same goes for renal protection also. Okay, and hence the steroid hormone interaction is more with this, and it decreases with eplerenone and phenrenone. So this is what is happening. This is what is the difference between the three mineralocorticoid receptor antagonists. Now we will look at the options which they have given here. So what have they given regarding phenrenone? It has cardioprotective effects. Is it true or false? Yes, it is true. It is a non-steroidal mineralocorticoid receptor antagonist. Very true. Just now we saw it is a only non-steroidal mineralocorticoid receptor antagonist. It causes less hyperkalemia when compared with spironolactone. This is also true. It produces marked blood pressure reduction. This is what is false. Because what did we see? We saw the blood pressure reduction is lowest with the phenrenone, and it is very high with spironolactone. So this is the major difference. Clear? So now we will move to the next question. A 28-year-old woman with multiple high-risk sexual exposures is seeking prevention for HIV infection. So they are asking which of the regime is involved for HIV prevention. So this is very important. So please pay attention here. So what is the preferred first-line regime in adults? The preferred first-line regime is the TLD regimen. I hope you all know. What is TLD stands for? Tenofovir, lamivudine, and dolutegravir, right? So tenofovir is a nucleotide reverse transcriptase inhibitor, whereas lamivudine is a nucleoside reverse transcriptase inhibitor, and dolutegravir is an integrase transfer inhibitor. So this is the preferred first-line regime. But what is the regime which is used for pre-exposure prophylaxis? For pre-exposure prophylaxis, the regime is tenofovir and emtricitabine. Please note, for pre-exposure prophylaxis, you give dual therapy, which is tenofovir and emtricitabine. And what about for post-exposure prophylaxis? For post-exposure prophylaxis, it is the same TLD regime, what you saw before. And when should you start this post-exposure? Within 72 hours of exposure, you need to start. And this regime has to be given continuously for 28 days. Clear? This is about the post-exposure. Pre-exposure, it is a dual regimen, whereas for post-exposure, it is a TLD regimen. It should be started within 72 hours for the maximum protection, and the regime should be given for a month period. And what about in pregnancy? Even in pregnancy, the same regime is followed, which is the TLD regimen. There's no doubt in it. Now, what will we give to the babies who is born, whose mother is HIV positive? In this case, what do we do? So, we divide these babies into low-risk infants and high-risk infants. So, for low-risk infants, the regime is either you go for zidovudin or nevirapine syrup for 6 weeks. So, either one you can choose. Whereas for high-risk infants, it is zidovudin plus nevirapine. Both should be given and the same duration, which is 6 weeks. And if the baby is breastfeeding, please note, breastfeeding is not contraindicated in HIV. Breastfeeding can be done, but with cautiously. In case of breastfeeding, it has to be extended to 12 weeks. This is the major difference. Clear? And how do we define this high risk and low risk infants? Low risk infants means when the copies of the viral load is less than 1000 units per ml, then we call it as low risk. This should be measured at 34 weeks of pregnancy. At 32 to 34 weeks of pregnancy, if she has a viral load of less than 1000, then they come under low risk. And who is high risk? If the viral load is more, or if the mother did not take HIV regime properly, or if she is taking it non-adherently, okay, she takes for one day, she forgets for the other day. So in this case also, even if the viral load is minimal, they have to be categorized under high-risk infants. So what is the answer here? For pre-exposure prophylaxis, it is tenofovir. We said it is a dual regimen, which is tenofovir and emtricitabine. Please note, for all other, it is the TLD regimen. Clear? So now moving on to the next question. A patient is receiving treatment of MDR-TB, multi-drug resistant TB, and now he develops progressive tingling, numbness, and burning sensation in both feet. Now, when you remember of tingling, numbness, what is the first drug which strikes your mind? It is INH. Okay. So yesterday we saw a tabular column, a table, which incorporated all the areas of the TB drugs, if you remember. So under that, if you remember, there's one more drug which caused peripheral neuropathy, which is there in the option. If you recall, it is linezolid. Okay, so I will put the table again for you. This is the table yesterday we saw, right? In this, INH is the one causing peripheral neuropathy. And for what you're going to give pyridoxine, this we already know. There is one more drug which causes peripheral neuropathy, which is linezolid. Yesterday, we saw one more adverse effect, hypothyroidism, if you remember. Hypothyroidism is seen with the two drugs, which is PAS and ethionamide. So please do not forget, there are two drugs which causes peripheral neuropathy, which is linezolid and isoniazid. And hence, the answer here is linezolid. Okay? Now moving on to the next question. A patient of pulmonary tuberculosis, this is the same question yesterday we saw, is advised to take rifampicin on empty stomach. So which of the following is false, they are asking. So rifampicin commonly occurs rifampicin resistance occurs due to the mutation in the RPOB gene. It is true. Yesterday only we saw it is because of the mutation in the RPOB gene. And of course, it undergoes enterohepatic circulation. And it is a potent microsomal inducer. Just now we saw, okay? And the one thing also we saw is it has to be taken in an empty stomach because food interferes with the absorption. So the false one is fatty meals increases its absorption. So this is the answer. So now moving on to the next question. The next question is, a 38-year-old HIV positive patient. He presents with fever, headache, neck stiffness, and raised intracranial pressure. And the lucky part is they have given the diagnosis here. What have they given? So there is a HIV patient and he has received an opportunistic infection, and this infection is cryptococcal meningitis. And what they have asked, which is preferred as an induction regime. So this part you have to see carefully. Induction regime. What is the meaning of that? Because there's something also called as maintenance regime and consolidation regime. So for the treatment of cryptococcal meningitis, you need to start the treatment in 3 phases. That is induction. Induction means you're going to start it with amphotericin B and flucytosine. Please do not forget. It is amphotericin B and flucytosine. And under consolidation and maintenance therapy, you're going for the azole, which is fluconazole. Okay. So these are the only drugs which is used for cryptococcal meningitis. And since they are asking the induction regime, the answer is going to be amphotericin B and flucytosine. Okay, so I'm not going to start with this. This is going to be one of the opportunistic infection they are asking. There are chances that they may ask the drug of choice for any of the opportunistic infection. We saw only cryptococcal meningitis. So what do I insist? I insist you to please learn this table. This table doesn't need a separate explanation. This has to be memorized by you. Okay. For example, I will take a few easiest things for you. Candidiasis. For oral and esophageal candidiasis, the drug is fluconazole. So what I am telling is, please club together and learn. Okay. There is one more azole which will be coming here. Histoplasmosis. For that, you're going to use itraconazole. Okay. And for Mycobacterium avium complex, is it acetomycin and clarithromycin? And cytomegalovirus, it is ganciclovir. Okay. Pneumocystis, it is cotrimoxazole. Okay. So please remember this table. Opportunistic infection is also a high yield question for you. So please see this before you're going. Sometimes, as I said, in this question, luckily they have given you the diagnosis. Sometimes they will miss the diagnosis. They will just tell the symptoms and the features and they will not tell you the exact diagnosis. In those conditions, what do I do? So there will be some clues in the question. The first clue will be either they will be telling the CD4 count of the person. Okay. If the CD count is less than 200, it is mostly pneumocystis. If it is less than 100, it is toxoplasmosis. And if it is less than 50, it is mostly cytomegalovirus and Mycobacterium avium complex. And similarly, they will tell raised ICP, which is most commonly associated with cryptococcal meningitis. And if they are insisting like ring lesions is present, it may be toxoplasmosis. Okay. So severe immunosuppression, that is what I told here, less than 50. There are more chances of CMV and MAC. Okay. So please look at the question carefully and then answer. Now moving into the next question. A patient with refractory rheumatoid arthritis is enrolled in a clinical trial evaluating a epigenetic drug. Okay. So this is the keyword here. Epigenetic drug that suppresses the cytokine production, including TNF-alpha and IL-6, along with the reduction in the B cell. Which of the following mechanism explains these effects? Please remember, epigenetic drug means it can act by 2 mechanisms. One is histone deacetylase inhibition, and the other is DNA methylation. Okay, so either of these two it can act, and most of the anti-inflammatory property which is exhibited by the epigenetic drug is mostly because of histone deacetylase inhibition. The anti-inflammatory property is mainly because of HDAC inhibition. So this is the answer. What is the answer? The answer is histone deacetylase inhibition. You need not think about the other answers. And please note, there is no epigenetic drug which is approved till now for the treatment of rheumatoid arthritis. Clear? There is one drug which also inhibits HDAC inhibition, and it comes as a minor mechanism of action. Anybody can guess what drug it is? It is theophylline, which is used for asthma. That also inhibits HDAC. Okay, right. So these are the drugs which is used for rheumatoid arthritis. We will see about these drugs like very briefly in the upcoming slides. Okay. So now we will leave this for now. So what we have seen now, epigenetic means, and if the epigenetic and anti-inflammatory word comes, then the next thing should be histone deacetylase. So remember that. Now moving into the next question. A 58-year-old man with dilated cardiomyopathy and reduced ejection fraction is started on an evidence-based therapy which is shown to improve the long-term survival. Which of the following beta blockers has proven mortality benefit in this condition? So, what is the problem in cardiac failure? The cardiac failure, although we are treating based on the symptoms, the symptomatic relief the patient is getting, the final thing we need to treat is to prevent this cardiac remodeling. So what are the drugs which prevents the cardiac remodeling? The drugs which prevents the cardiac remodeling are, the first is RAS inhibitors. So what are RAS inhibitors? All your ACEIs, ARBs, your neprilysin inhibitors, all comes under RAS. The second is mineralocorticoid receptor antagonist. The drugs we saw before, spironolactone, eplerenone, finerenone, also helps in cardiac remodeling. And the third is beta blockers. Remember, not all beta blockers are proved efficacious. It is MBC beta blockers. What is MBC beta blockers? MBC beta blocker stands for metoprolol, bisoprolol, and carvedilol. It is only these three beta blockers which is approved for heart failure, okay, which is shown to improve the remodeling, to prevent the remodeling in the heart. Okay. Anything else we missed? There is a fourth category, which is also a drug which is used for diabetes mellitus, which is SGLT2 inhibitor. Okay. So among the option, do we have any of these three drugs, metoprolol, bisoprolol, and carvedilol? Yes, we have option C, carvedilol. So the right answer is option C. Now moving into the next question. A 61st question. A patient with episodic migraine is prescribed rimigepant for acute treatment. Which of the following statement is true? See, migraine is also a hot topic, okay, because there are many new drugs which are introduced in migraine, okay. So we will take a few time to see what migraine is so that we will be able to answer many of the questions which is upcoming. So what is migraine caused due to? The migraine is caused because of the stimulation of the trigeminal nerve. So what does it cause when the trigeminal nerve is stimulated? As you can see, in the trigeminal nerve ending, there is 5-HT1D receptor. And also there is going to be one more receptor, which is 5-HT1F receptor. Okay. So when it is stimulated, there is going to be release of neurotransmitters. And what neurotransmitter it is? It is CGRP. Okay. The CGRP neurotransmitter is released. And what does the CGRP do? The CGRP, it goes and binds to the 5-HT1B receptor on the blood vessels, and it causes vasodilation, which is the cause of the headache in migraine. And what else it can do? It can also go and act on the mast cells, and it can also produce inflammation. So how we are going to target the drugs? We are going to target the drugs. Either we can give agonist to 5-HT1F, or we can give agonist to 5-HT1D. If we give agonist, what happens? That is, it is in the presynaptic receptors, so it is going to inhibit the release of the neurotransmitter. Please understand this. So when you're giving an agonist, it is going to inhibit the release of CGRP. And here also 5-HT1B receptor, if you give, what happens? It will lead to vasoconstriction. As you can see, it leads to vasoconstriction. And the third thing is you can give an antibody against the CGRP receptor. Okay, so if you give an antibody, the CGRP cannot go and block here. Otherwise, what you can give? You can give a antagonist also against the CGRP. So, what are the drugs which is indicated? So, for simple migraine, that is for mild migraine, you need not start with any of the high drugs. Go for simple analgesics and NSAIDs, and that would suffice. And this is going to decrease your prostaglandin synthesis, and it is going to give a good effect. And the next group of drug, if the patient is not responding to NSAIDs, the next will be your triptans. The triptans going to act on your 5-HB, 1B and 1D receptor agonist. And thus it is going to cause vasoconstriction. Okay, migraine is because of vasodilation. It is going to cause vasoconstriction. And what about ergoids? Ergoids also has 5-HT agonism. In addition, it also has alpha agonistic activity also. So this is going to cause more vasoconstriction. This is the reason these two drugs, it should not be given together. Don't give it together, okay? It can cause extreme vasoconstriction. And now coming to our new drugs. So we saw triptans, right? In similar way, we have gepants and ditans. What are gepants? Gepants are nothing. They are CGRP receptor antagonist. Under this, you have two drugs, which is ubrogipant and remigipant. And you have 5-HT1F agonist, and this is ditan, which is lasmiditan. Okay, so these are the gepants and ditans which is used for treatment. So remember, triptans for Okay, so sorry for the inconvenience caused. We will continue this. So what I was telling that detents, okay? The detents mechanism of action is it is 5-HT1F agonist. So please remember for migraine, triptans are the first choice of drug. And if triptans is not working, then you're going for Qbanks and detents, okay? So now we are going to see about the main difference between the Qbanks and detents. As I said, Qbanks are CGRP receptor blockers, antibodies, whereas it is not, it is not CGRP receptor antagonist, whereas the detents are 5-HTF receptor agonist. And the advantage of both is that these both drugs, it doesn't cause vasoconstriction, and hence it can be safely be given in patients with angina and hypertension, where triptans are contraindicated. And the next best thing is the ADR profile. The ADR profile is very low. Okay, detents can cause sedation and Qbanks are prone to cause nausea. Other than that, the tolerability profile for both is the same. So please remember, for mild migraine, NSAIDs is more than enough. For moderate migraine, go for triptans. If the patient is not responding, you can add a Qbank or detent. And for severe, you need to go for prophylaxis. And what are the drugs which is used for prophylaxis? You have many drugs such as beta blockers, tricyclic antidepressants under which amitriptyline comes, and you have topiramate and valproic acid anti-epileptic, flunarizine, which is a CCB, and you also have one more CGRP modulating drug, which is erinumab, fremanizumab, and galcanizumab. So what are these? These are monoclonal antibodies against CGRP receptor. And one more interesting finding is that Qbanks can also be used for prophylaxis. So please remember, the only drug which is used for both prophylaxis and treatment are Qbanks. The only CGRP drug which is used only for prophylaxis are the monoclonal antibodies. Okay, so with this, we will try to answer our question. So our question are, what is the true about remigipant? So we already saw these are oral drugs. It can be very well given orally. So it can be administered subcutaneously is a false statement. It causes cerebral vasoconstriction. This is also false because triptans and ergots are the only group of drugs which causes cerebral vasoconstriction. And they are CGRP receptor antagonist. It is not a partial agonist. And it is excreted in feces. This is the true thing. Okay, so this is the true statement. Now moving on to the next question. So in our next question, we are seeing about dengue fever. Okay, the patient is having a dengue fever and the platelet count is 20,000 and he is hemodynamically stable. There is no bleeding. Okay, so now what is the management? So please remember, platelet, if the platelet is, even if the platelet is low, if the patient is hemodynamically stable, if he is hemodynamically stable and if he has no active bleeding, it is enough to manage him with supportive care and management. Don't rush for platelet transfusion. So this is the moral of the story. Only if the patient is having active bleeding, then you have to go for the platelet transfusion. So the answer here is supportive care with paracetamol and monitoring. Now going for our next question. A 42-year-old diabetic, he is presented with distal lateral subingual discoloration and thickening of the toenail, great toenail. That means there's going to be some nail infection, which is most probably fungal, and they also has it, the nail scraping, it confirmed it is a fungal infection. And now they have given a drug, and this drug inhibits fungal leucine tRNA synthase. So, as I said, I am giving you tables for some of the few important things. The same way I'm giving it for antifungal also. You need to remember the mechanism of action of the antifungal drug and in which drug is used as a drug of choice for what condition. So, under that, you have the drug which is tavabarol. This is inhibiting the leucine tRNA synthase and it is specifically used for topical onychomycosis. So tavabarol is a drug which inhibits leucine tRNA synthase and hence that is the answer, which is option B. Now moving into our next question. A 35-year-old sheep farmer, he presents with fever, right upper quadrant pain, eosinophilia, and hepatomegaly. And our diagnosis is fasciola hepatica. Okay, they're asking what is the drug of choice. So I know you're going to hate me from here, because this also you're going to put effort from your side, because for fasciola hepatica also you need to remember the drugs. So for fasciola hepatica, what is the drug of choice? It is going to be triclabendazole. Okay, for histosoma it is praziquantel. For neurocysticercosis, it is albendazole, and enterobius you can use either albendazole or mebendazole. So here the answer is option C. Okay, I'm not going to stop here. I'm also going to give a list of drugs of choice for other infection of the parasites. As you can see, starting from fasciola hepatica, histosomiasis, clonosis sinuses, and tinea solium, everything, till you have a list. The list is going to get bigger and bigger. So now how do I learn this? Remember it drug-wise. That is the simplest one. For example, please remember, like albendazole, it is given for what infections? Praziquantel is given for what infection? Okay, so please try to club together the infections and learn. Then it is very easy for you to learn, right? So you have, because you have only a very less amount of drug which is going to be used repeatedly for many of the infections. Okay, but here our question is mostly concerned with fasciola hepatica, and triclabendazole is our answer. And this triclabendazole is not going to be used in any other parasitical infection, if you note. It is going to be used only in fasciola hepatica. Okay. Now moving into the next question. Match the following drugs with the condition that they are used in. Yesterday we saw a list of antidotes, if you remember. Okay. So with that we will try to match. So which is the easiest one among this? We know about opioids. And for opioids, what is the drug? It is naloxone. So we have already fixed one. D is 4. And for smoking cessation, is there any drug among this? Yes, there is a drug called varenicline. So C goes for 3. And what is varenicline? Varenicline is a partial nicotinic receptor agonist, which is used for smoking cessation. Okay. And now you have two things. Delirium tremors. For delirium tremors, in order to control the delirium, you are going to use benzodiazepines immediately. And the benzodiazepine listed out here is oxazepam. So it is A2. And for acute alcoholism, what do you have? Acute alcoholism, you are going to use acamprosate. So this is the right order of drugs. So I will give you a simple thing about what to answer if they ask the other things also. So for alcohol, for methanol, like for the normal alcohol, which is ethanol, if they ask you what do you do for acute intoxication, it is mostly symptomatic treatment. For withdrawal, the patient is going to have delirium. There you are going to use benzodiazepines, which was asked in the question. And for prevention and maintenance, you can use acamprosate. That was also asked in the question. In addition, you have one more drug, disulfiram. Also, you can use naltrexone also. Okay, these 3 drugs can be used for alcohol maintenance therapy. And what about opioids? For opioids, for acute, what are we going to use? We are going to use naloxone. And for withdrawal, what we are going to use? We are going to give buprenorphine. What is buprenorphine? It is a partial agonist. Okay, so buprenorphine can be given for withdrawal treatment. And for maintenance, what we can give? Naltrexone, which is given via oral route. And for nicotine, you can go for nicotine patch. Nicotine patch. And for maintenance, just now we saw a drug, varenicline. And for benzodiazepines, the acute intoxications, you can go for flumazenil and you can maintain it and you can treat it symptomatically. For methanol, it is fomepizole, and even for ethanol also it is going to be fomepizole, and benzodiazepines plays a role in withdrawal treatment also. And for cocaine and cannabis, it is mostly symptomatic treatment throughout. Okay, so do not forget this. Now moving into the next question. A patient came in for a follow-up after post-MI and his cholesterol is 238, triglyceride is 125 and HDL is 50. So look at the list of drugs he is taking. He is already on a statin, which is atorvastatin, and he's on metoprolol and aspirin. Since his triglycerides and cholesterol is not controlled, they're asking which medication should be added to his regimen. Okay, so they have listed you a list of drugs, which is ezetimibe, bempedoic acid, evolocumab, and gemfibrozil. Yesterday, we saw about a few of these drugs yesterday. Okay, if you remember about this, PCSK9 inhibitors. Yesterday, I told you what is this inhibitors going to do? This inhibitors is helping in the recycling of the LDL receptor back to the surface. How? It is going to inhibit the PCSK9 molecule, which is attached to the LDL receptor, so that both the LDL receptor and the LDL molecule will not be degraded. This is about the PCSK9 inhibitors. Clear? And here you have alirocumab, evolocumab as the drugs. And the next drug they have quoted is ezetimibe. What is ezetimibe? Ezetimibe is a cholesterol absorption inhibitor. How is it going to inhibit the cholesterol absorption? It is going to inhibit Niemann-Pick C1 like 1 transporter, which is responsible for the absorption of the cholesterol into your small intestine. Since this is inhibited, what happens? The cholesterol will not be absorbed. So there's going to be decreased in LDL. In response to this, the LDL receptor will also increase, and this helps in capturing more LDL. So this is about the mechanism of action of the drug, which is ezetimibe. And now coming to the other drug, which is bempedoic acid. Yesterday, we saw about this drug too, if you remember. What is bempedoic acid going to do? Bempedoic acid is going to inhibit ATP citrate lyase. It is going to act upstream to statins. Statins, where does it act? Statins is going to inhibit the HMG-CoA reductase enzyme. What is the advantage of bempedoic acid? It is a prodrug. It gets activated only in the liver, and hence there is less chance of myopathy. Whom it can be given to? It can be given to patients in which statins they are not responding. This is about bempedoic acid. Okay, and as I said, statins, it causes myopathy, and this reason of myopathy is because of that the HMG-CoA reductase enzyme not only inhibits the cholesterol synthesis, it also inhibits the CoQ10 synthesis also, which is needed for the ATP mitochondrial electron transport chain, and hence the ATP synthesis will be affected, and decreased ATP in the muscle, it is going to cause myopathy. So this is the reason. Okay, so what drugs are we going to add? Which medication should be added to this regimen? All the three, ezetimibe, bempedoic acid, and evolocumab, all the three can be added to his regimen. Why gemfibrozil is added? This is where it is important. Please understand, statins and fibrates is a dangerous combination. It should not be given together. Why? Because statins, it acts in the liver, as you know. It is going to be taken into the liver with the help of a transporter, OATP transporter. This fibrates, it inhibits the OATP transporter. Hence, statins will not be taken into the liver. Now, what happens? The blood levels of statins will increase, and this can also cause myopathy. Okay, so the myopathy is going to get worsened. That is why we are not going to combine statins and fibrates together. And we are going to leave this gemfibrozil, which comes under fibrates, and we can add all the other drugs also. Okay, so now we will move into the next question. So our next question is, A patient is diagnosed with uncomplicated Plasmodium falciparum. Please note what is the species here? It is Plasmodium falciparum. So they are asking which of the following drugs does not have a primary role in the treatment of falciparum. So the treatment of malaria is very important. The only regimen which hasn't changed for many days is malaria regimen. So it is very easy for you to remember. So please note, we are dividing malaria into complicated malaria and uncomplicated malaria. If it is uncomplicated malaria due to any species except falciparum, the treatment is going to be chloroquine phosphate, tablet chloroquine. In addition to that, you are going to add primaquine also. Okay. And chloroquine, how many tablets? 4 tablets stat, 2 tablets after 8 hours, and 1 tablet BD for 2 days. And each tablet, this is also important, it contains 250 mg of the active ingredient. At 250 mg, each 250 mg contains 150 mg of the active ingredient, and the rest is salt. Okay. So please remember, for uncomplicated malaria, it is chloroquine phosphate plus primaquine OD for 14 days to prevent relapse. And what if it is falciparum? Here comes the twist. For falciparum, if it is complicated or uncomplicated, it doesn't matter. Okay, for both complicated and uncomplicated, if you get the word falciparum, then the treatment regime is always going to be ACT. Do not use chloroquine. Chloroquine resistance has developed for falciparum. So chloroquine is strictly contraindicated for falciparum. The word complicated and uncomplicated is added to confuse you. So if you see falciparum, please go for artemisinin combination therapy. There are many ACTs which is available. Okay, any one of the ACT can be used. Like one of the example here I have given is artesunate and sulfadoxine and pyrimethamine. Here also, in order to prevent relapse, you have to give primaquine. But the dose of primaquine is just a single dose. Over there, you are going to give for 14 days. Okay, here it is going to be a single dose. Except, please note, in northeastern states alone, there is going to be only one specific regimen which is going to be used, which is artemether lumefantrine, because that is more sensitive there. The falciparum over those areas are more sensitive to artemether and lumefantrine combination. So it is used only there. And if you get a mixed infection, what do I do? Mixed infection means falciparum is going to be there. Since falciparum is there, I'm going to go for primaquine only. Since other infections are also there, what am I going to do? I'm going to put my primaquine here. So primaquine 15 mg for 14 days will be coming here. Clear? So please remember, for uncomplicated malaria, it is chloroquine plus primaquine. For falciparum, it is ACT and primaquine, and here primaquine is a stat dose. Okay. For mixed infection, it is ACT plus primaquine, but here the primaquine is for 14 days. Okay. So now what is the question? Which does not have a primary role in the treatment of uncomplicated? Remove this word. It is a confusing word. Okay. If you see uncomplicated, delete it from your mind. Falciparum is important. So what is the answer here? Artemether, pyrimethamine, sulfadoxine, and pyrimethamine. This comes under ACT. Okay. So the option here is chloroquine. The correct option is chloroquine. Now coming to the next question. A 60-year-old diabetic patient, he complains of burning feet, shooting pain, and severe allodynia. He also has history of post-herpetic neuralgia following herpes zoster. So the question is, which drug is useful in neuropathic pain, which is associated with spinal cord injury? So they have given a list of drugs. So we will see what these drugs are. See, for neuropathic pain, there is many drugs which can be used. The very first drug is pregabalin. This pregabalin is mostly used for all types of neuropathic pain. Can you tell me where carbamazepine is used? Yesterday we saw it is used for trigeminal. It is actually the drug of choice for trigeminal neuralgia. And amitriptyline. Amitriptyline can also be used for neuropathic pain, especially if it is associated with depression also. And duloxetine can be used for neuropathic pain, which is associated with DM. Okay, so all these drugs are used for neuropathic pain. Now, how does this pregabalin work? This pregabalin inhibits the calcium channel. Clear? So by decreasing the neurotransmitter, it is going to give you a relief from the neuralgic pain. So remember, pregabalin is not only, as I said, it is used in most of the cases of neuropathic pain, such as diabetic neuropathy, post-herpetic neuralgia, neuropathic pain due to spinal cord injury, fibromyalgia, and of course, it can be used as an adjunct in partial seizures. It is the very least use. Okay, and now what is the major difference between pregabalin and gabapentin? Which is more potent? Of course, pregabalin is more potent. Gabapentin is less potent when compared to pregabalin. And the pharmacokinetics is variable with the gabapentin, and it is not so. It is fixed pharmacokinetics with pregabalin. And neuropathic pain, it responds very well to pregabalin than gabapentin. Okay, so which is better? Pregabalin is always better. So the answer here is pregabalin. Why? Carbamazepine, as I said, it is used for trigeminal neuralgia. Okay, and amitriptyline, it is when compared to amitriptyline, pregabalin would be the best answer. Okay, this can be used if they are saying there is history of depression. If they have quoted, then you can go for amitriptyline. Okay. Now coming to the next question. A 46-year-old woman. He was started on fluoxetine for major depressive disorder. And now she develops neuropathic pain. 2 weeks after starting an analgesic therapy, she experiences syncope and the ECG finding is shown. So what does the ECG show here? See, this ECG, it denotes prolongation. QT prolongation. How do I see QT prolongation? If my QT interval is more than half of my RR interval, this means that it has QT prolongation. So you need to count at the number of big squares and the small squares. Okay. So if you look at the big squares, so when I was seeing this ECG, the QT interval was seen to be higher than half of the RR interval. This means that some QT prolongation has happened. So you can check and see. You can see how many boxes are coming. You can see the QT and RR and calculate accordingly, and you will definitely see a QT prolongation in this ECG. Now, what am I telling is, we will come to the drug side here. So they are telling that they are given fluoxetine here, right? And fluoxetine followed by some analgesic. And now she has developed QT prolongation, and what is the reason? Okay, so what does this mean? There is going to be, and they have given a list of drugs which they have been given for pain relief. Sorry, pain for pain relief. Okay, so now there are a list of drugs which causes QT prolongation. So what are the drugs which causes QT prolongation? You have drugs from every class. Antiarrhythmics, we will deal with this class very detailed. Among this, you have class 1A and class 3 drugs which causes QT prolongation. You have haloperidol and ziprasidone which causes QT prolongation. Tricyclic and antidepressants and methadone among the opioids and other antibiotics, antifungals, ondansetron, your chloroquine, and also your lithium. It can cause. Yesterday we saw lithium can cause QT prolongation, right? So among the options, is there any pain relieving drug? We have an opioids, which is methadone. So we will look at whether methadone is present. Yes, it is present. So this is the culprit here. This methadone has caused QT prolongation in this lady, and this has led to syncope. Clear? So now we'll move to the next question. A child with sickle cell disease, he experiences recurrent painful vaso-occlusive crisis. Which pharmacological intervention has proven benefit in reducing the painful crisis by, this is very important, by decreasing the fetal hemoglobin levels? Okay, so now we will look at the drugs which is used for sickle cell anemia. So what are the drugs which is used for sickle cell anemia? The first is hydroxyurea. What does hydroxyurea do? The hydroxyurea is going to increase the hemoglobin, especially the fetal hemoglobin HbF. And by increasing the HbF, it is going to reduce the polymerization of RBCs. And hence, there's going to be decrease in painful crisis, decreased hospitalization, decreased transfusion requirement, and decreased chest syndrome. So the hydroxyurea is the drug which increases the fetal hemoglobin levels. Is this the only drug available? No, you have other drugs also. As I said, hydroxyurea, it increases the HbF and it reduces the polymerization. And there is one more drug which is given, which is called as L-glutamine, which is going to have an antioxidant action. And this is also used in sickle cell anemia. And you have an monoclonal antibody, which is crizanlizumab. And what is this going to do? This crizanlizumab is going to act as an inhibitor for P-selectin. And what does this selectin has to do? This P-selectin is responsible for the attachment of the RBCs to the blood vessels. So once this is inhibited, then trapping of the RBCs and the polymerization will also be inhibited. And voxelotor is also a drug which was approved before, and this also decreases the HB polymerization. But the only drug which increases the fetal hemoglobin and reduces the polymerization is hydroxyurea. And hence, what was our answer here? Which is a drug which increases the fetal hemoglobin? It is hydroxyurea. Now moving into the next question. A bipolar disorder patient is on a long-term mood stabilizer, and now he presents with lethargy, vomiting, elevated liver enzymes, and hyperammonemia. Now, we have a tendency. If we see bipolar, then what answer we will go and choose? Lithium. No, don't do that. What is the keyword here? Hyperammonemia. Yesterday, when we are discussing anti-epileptics, I gave you a table. Under that table, under valproate, you can see the side effect of hyperammonemia. So the answer for this question is valproate. Now we will have a quick look at what are the drugs used for mania. So the main drug, the drug of choice for mania is actually lithium. Okay. If not lithium, then valproic acid. And for prophylaxis, other atypical antipsychotics. And for immediate symptom relief, benzodiazepine, all these can be used. This we know already. Now, for prophylaxis, what drug can be used? Prophylaxis also, lithium forms a gold standard prophylaxis. If the patient is not tolerant to lithium, then he can go for valproate. So valproate forms the second choice of prophylaxis. If not, we can go for lamotrigine or quetiapine. So this is the list of prophylactic drug which is going to be given for mania. So how is this lithium going to work? This lithium, it is going to inhibit the enzyme inositol monophosphatase. And by inhibiting, what does it happen? It inhibits right at this site. So inositol monophosphate will not be converted into inositol. So all these steps will be affected. And hence, the phospholipase C will also get affected. And the intracellular signaling is getting affected. So IP3-DAG signaling will not happen. And hence, no response is elicited. Okay, this is how it is going to help patients of mania. That is, it is going to inhibit the inositol monophosphate pathway. If you want to know about lithium, it is a narrow therapeutic range. 0.6 to 1.2 milliequivalent per liter. This is the therapeutic range. Okay, and you also have to know about drugs which increases the lithium. The main diuretic which increases the lithium is thiazide diuretic. In addition, NSAIDs and ACEIs can also increase your lithium level. Please note this. Okay. So in this question, what did we learn? That we learned the first drug for prophylaxis and treatment is lithium. When it is coming to prophylaxis, the second line of drug which can be given is valproate. But valproate causes the area of hyperammonemia. And we also saw about the mechanism of action of lithium and the drugs which is going to increase the lithium level. And now coming to the next question. A woman is receiving chemotherapy for breast cancer and there is decline in the left ventricular ejection fraction. That means there is some cardiac toxicity which is happening. Okay. So which drug is useful for preventing and treating this toxicity? So this cancer related, the chemotherapy related toxicities is also one of the high yielding questions for you. So what are the drugs which can be given? See, bone marrow suppression is most common when you treat with an anti-cancer agent. So for bone marrow suppression, what drug we can give? It depends upon what blood cell is depleted. If there is so remember, if the patient is going to have anemia, you're going to give epoetin or darbepoetin alpha. If the WBCs are declined, you can go for two things. One is GCSF and other is GMCSF. What is GCSF? GCSF is granulocyte colony stimulating factor, which increases your neutrophils. Whereas GMCSF, it increases your neutrophils. In addition to that, it increases your monocytes also, eosinophils. All these can be increased when you give GMCSF. So under GCSF, you have two drugs, filgrastim and the pegylated form of filgrastim, which is pegfilgrastim. Okay. Under GMCSF, you have malgromostim, regramostim, and sargamostim. For thrombocytopenia, what do you give? You can go for TPO agonist, that is thrombopoietin agonist, which is romiflostim or L-thromboplaque, or you can give for recombinant IL-1, which is opriloquine. And for cardiotoxicity is dexrazoxone, and this is the answer. They have asked what is given for cardiotoxicity, right? And for xerostomia, you can go for amifostin. And what are the other drugs which can be given? For CINV, I will deal CINV very detailedly, so you leave this for now. For renal toxicity also, you can give amifostin. Where else it was used? For xerostomia, it was used. And while learning about the antidotes, we saw for hemorrhagic cystitis, we can give Mesna. And for hyperuricemia, rasburicase is preferred. It is not allopurinol. Rasburicase is preferred. And for hand-foot syndrome, it is corticosteroids. Okay. Now I'm going to deal with CINV in detail. See, the treatment of CINV, it can be based on two. One is treatment. The other is prophylaxis. Okay. So the treatment, how are we going to divide? Whether it is acute CINV, if the vomiting is acute, that is, if it is developing in less than 24 hours, or delayed. Delayed means more than 24 hours. If it is acute, the drug of choice will be 5-HT3 receptor antagonist, such as ondansetron, granisetron, all those. If it is delayed, in addition to this, you're going to add a steroid, DEXA, or you can also add NK1 receptor antagonist, which is aprepitant, fosaprepitant, and all those. This is for the treatment. And for prophylaxis, we are going to classify the drug risk-wise. If we are going to classify the drug risk-wise. If the chemotherapeutic agent has minimal risk of causing CINV, then no drug is needed. If the drug is having low propensity to cause CINV, then one drug. And what will be the one drug? It is going to be a 5-HT3 antagonist. That is going to be the one drug. If it is moderate, in addition to 5-HT3 antagonist, you can go for DEXA. If not DEXA, you can go for NK1 receptor antagonist. If not NK1 receptor antagonist, you can go for olanzapine. This is one new addiction. Why olanzapine? Olanzapine, it comes under atypical antipsychotic. This olanzapine, it also has some amount of 5-HT3 blockade also and some D blockade, dopamine blockade also. Hence, this olanzapine can also be used. Please note it is not used solely, it is used as an add-on. If it is high risk, we are going to combine all these together, the 4-drug regime, that is 5-HT3, DEXA, NK1 receptor antagonist, and olanzapine. Okay, so this is going to be the treatment of CINV. So here the answer is for cardiotoxicity, what is it? It is dexrazoxone. Okay, these two are used for CINV, and amifostin we saw it is used for xerostomia. Okay, and also for renal toxicity. And now coming to the next question. A 12-year-old boy, he comes with complaints of profuse watery stools and elevated WBC, and he is on treatment for amoxicillin for the past 1 week. So what is the treatment of choice? So the diagnosis in this condition is C. difficile, which is Clostridium difficile infection. And what is the drug of choice for Clostridium difficile infection? So the treatment of C. difficile is, for initial infection, you can go for fidaxomicin or oral vancomycin. And the infection is very severe. If it is a fulminant disease, you can go for oral vancomycin and you can add IV metronidazole here. The point to be noted is, it is only oral vancomycin. However severe the infection is, it is not IV and vancomycin. Please note this difference. Why? Only oral vancomycin, it can get concentrated in your gut lumen. And that is why we are going for oral. IV, it doesn't concentrate in the gut lumen. Clear? So this is why we are using oral vancomycin for both the cases. So in this question, what is the answer? It is fidaxomicin. So remember, there are only 2 drugs, fidaxomicin and vancomycin. It is fulminant. You are going to add metronidazole to it. And now coming to the next question. A 25-year-old male, he presents with severe purpuric skin lesions and is diagnosed with idiopathic thrombocytopenic purpura. Which of the following tyrosine kinase inhibitors can be used in this condition? Now, what is the treatment of ITP? Please remember, if the question asks the drug of choice for ITP, it is going to be steroids. If they ask thrombopoietin receptor agonist, this we also saw in cancer chemotherapy toxicity also, the same drugs, eltrombopag and romiflostim. Okay. If they're asking a tyrosine kinase inhibitor, which is used in ITP, it is fostamatinib. Okay. So here what they were asking, a tyrosine kinase inhibitor. So there are, from the name itself, you can identify the tyrosine kinase inhibitor. It ends with nib. And here fostamatinib is a tyrosine kinase inhibitor. Bosutinib, it is used in CML. It has no role in ITP. This is also a tyrosine kinase, but it is used in CML. And these are thrombopoietin agonists. Okay. So for severe bleeding, you should go for IVIG and refractory splenectomy. So these are the major 3 drugs which is used. And what is this fostamatinib? This fostamatinib, it is going to inhibit the SYK activation. What is, I already said, it is a tyrosine kinase inhibitor, right? So what is happening? The IgG-coated platelets, it goes and acts on it binds to the FC receptor on the macrophages. So once it binds, it activates spleen tyrosine kinase, which is called as SYK. And this is responsible for destruction. Our fostamatinib is going to inhibit specifically the spleen tyrosine kinase. Okay, so this is the mechanism by which this fostamatinib is going to act. Clear? So now moving into the next question, which of the following newly tricyclic antidepressant? What are the properties of tricyclic antidepressant? It is going to inhibit the reuptake of 5-HT, that is serotonin. Not only that, it also inhibits the muscarinic receptor. Yesterday we saw it inhibits the alpha receptors. It also inhibits the histaminic receptors. And in high doses, it inhibits one channel, which is the sodium channel also, which is the reason for arrhythmia. And this is why TCA is not preferred, because it blocks all this. There is going to be more areas. And what about first generation antihistaminics? The diphenhydramine, which they have prescribed here, is a antihistamine, especially first generation antihistamine. So what is it going to do? First generation antihistamine, what is the specialty? It can cross the blood-brain barrier and it can cause sedation. Okay, and this is also blocking the histaminic receptor. Now, what is the common thing? This is also blocking histaminic and this is also blocking histaminic. So now let us see at the options. Imiprabin inhibits the diphenhydramine metabolism. No, it has nothing to do with the metabolism. Both blocks muscarinic receptors. Of course, both blocks muscarinic receptors, because antihistaminics, as you know, the first generation antihistaminics, in addition to blocking histaminic receptor, it has an additional property of blocking the muscarinic also. Okay, so that is the reason it is also used as an antiemetic, especially in motion sickness. Okay, so both have muscarinic receptor blocking property and both have histaminic blocking property also. And are they norepinephrine reuptake inhibitors? No. Okay, so the right option here is both blocks the muscarinic receptors. Now coming to the next question. Which of the following statement is true about thalidomide? So let us see about thalidomide here. So how does this thalidomide work? So this thalidomide, it is actually used as an immunomodulator. So how does this immunomodulator function is happening? It inhibits the interleukin production, that is the cytokine production, especially interleukin 2, 5, and 6. All this is inhibited when you are giving thalidomide. In addition, it also causes free radical damage. It inhibits angiogenesis. And it promotes a cereblon protein. I will tell you what this cereblon is, okay? This cereblon is the main mechanism behind which it is causing the defects in the baby. That is teratogenicity. Okay. Now, thalidomide is used as a immunomodulator because of all this. Okay, because it reduces the cytokine production and it decreases the TNF. And this thalidomide, it is used in conditions such as multiple myeloma and also in type 2 erythema nodosum leprosum, type 2 lepra reaction. Okay, so the true thing is, of course, it is teratogenic to the fetus because it causes phocomelia. So this is true. It is used in the management, yes, because it helps in reducing the cytokines. And also for multiple myeloma, also it can be used. And the first point they are telling is the immunosuppressive action is because of anti-metabolite effect. It has nothing to do with anti-metabolite effect. It is only decreasing the cytokines in your body. So this is the false statement. So all these three are true statement. So the correct option here is option A. And now moving into the next question. Which of the following is true about GnRH receptor antagonist? Okay. So first let us see what is GnRH used for. The GnRH, what is the function? It is going to increase the level of follicle stimulating hormone and luteinizing hormone. Agree? So if you are going to give an antagonist, what is going to happen? the levels of FSH and LH is going to decrease. So this is the mechanism by which GnRH agonist is going to act. So in which conditions we don't want this FSH and LH? It is not needed for conditions like prostate cancer, where the testosterone level is high. And it is also not needed for endometriosis and also for uterine fibroids, which are estrogen dependent. And also, it is being used for IVF, in vitro fertilization. Why? It prevents the premature LH surge. This is the reason why it is used in IVF. So these are the 4 uses of GnRH antagonist. Your ganirelix, cetorelix, all the drugs which ends with relix comes under GnRH antagonist. So now let us look at the options. It is used for the treatment for hypogonadal hypogonadism in males. Already it is going to decrease the level of FSH and LHs and is going to cause hypogonadism only. So how can it be treated? How can it be used for the treatment? So this is a wrong statement. It is used in the management of advanced CA prostate. Yes, very right. It can be used in cases of prostate cancer. It is used as a tocolytic. Tocolytic is an agent that is going to relax the uterus. It has nothing to do with the tocolytic action. And it is used in vitro fertilization for controlled ovulation. This is an important word. Yes, of course. So the right answer is option B, which is 2 and 4. Now let us move into the next question. A patient develops bland cholestasis without inflammation, okay, following a prolonged hormonal therapy, which is classically associated with this pattern of liver injury. So the liver injury which is caused by drugs can be classified into 3. That is hepatocellular necrosis, which is caused mainly by INH and paracetamol-like drugs, or cholestatic hepatitis, which is caused by classically by amoxiclav, or bland cholestasis, which can be caused by steroids and estrogens. Okay, what is bland? There is no inflammation here. Okay, so what was our question? The question was causing bland hemostasis. And here comes our answer, which is estrogen and anabolic steroids. Okay. So this is going to cause hepatocellular, this is hepatocellular, and this is going to cause cholestatic hepatitis. Okay. Now moving into our next question. A patient with metastatic colorectal carcinoma is started on a monoclonal antibody targeting EGFR. Which drug is most likely to be prescribed? So previously, so same way, I have given the family of MAB and which acts on all EGFR, VEGF, on the bone, on the platelets. For everything, I have given you the maps. So from this family, we will select. What are they asking? It is given for colorectal carcinoma and it is going to target EGFR. So here we have 2 drugs which is given for colorectal cancer and it is also targeting the EGFR. What are the drugs? Cetuximab and panitumumab. And let us see whether it is there in the options. Yes, cetuximab is also there. Panitumumab is also there. So how do I choose? Cetuximab, as XI is there, it is chimeric. Hypersensitivity reactions are going to be more. Yet, I'm going to choose cetuximab. Why? Because cetuximab is mostly based on IgG1 and this is based on IgG2. Okay, since this is IgG1, it has more of antibody-dependent cytotoxic killing. The ADCC is more for cetuximab. That is why cetuximab, although it is chimeric, it is used for colorectal carcinoma, and the second choice will be panitumumab. Please remember this. And as I am telling, you need to remember, I can understand monoclonal antibodies is difficult to memorize, but you can give it a try. So to have a look at this. So especially even if you are avoiding the others, please try to learn the EGFR family alone, because most of the small molecule inhibitors and monoclonal antibodies, they are asking from the EGFR family most commonly. Okay. So now we will move into the next question. So as you can see, I have given you the whole list. Please go through the list. Everything is being concised into this. Okay. Now, the next question. Intermittent administration of teriparatide. What is teriparatide? It is a PTH analog, parathormone analog. It stimulates the osteoblastic bone formation. However, prolonged therapy is avoided because of which complication? So we usually, teriparatide, we give it intermittently. We don't give it continuously. Why? Now let us look at this. So this whole thing is a drug for it is given for osteoporosis. It's going to decrease the bone resorption and increase the bone formation. Out of this, teriparatide and abaloparatide are parathormone based. It is a PTH analog teriparatide, whereas abaloparatide is PTH-RP analog. And what is the most important ADR? Teriparatide causes osteosarcoma, whereas abaloparatide, it can cause hypercalcemia. Okay. And then comes our sclerostin inhibitor, which is romosumab, and cardiovascular risk is more. And for our favorite bisphosphonates, this bisphosphonates can cause jaw osteonecrosis and subtrochandic fractures. Okay. So similarly, you have denosumab also. This also shares the same common ADR as alendronate, which is jaw osteonecrosis. And then you have estrogen and raloxifene, which is also an SERM, and you have calcitonin itself. Okay. Now our question is, which is the long-standing complication when you are giving continuous administration of teriparatide? So what is it? It is going to be osteosarcoma, right? So bisphosphonates causes subtrochandic fractures and jaw osteonecrosis. Denosumab is also going to cause jaw osteonecrosis, and teriparatide is going to cause osteosarcoma. And calcitonin, it increases the chances of flushing. Okay. So the answer here is osteonecrosis of the jaw. Subtrochandic fracture is for bisphosphonates. Do not confuse. Sorry. I'm really sorry. They're asking about teriparatide. It is osteosarcoma. Okay. This too is for bisphosphonates. Clear? Osteosarcoma is associated with PTH, teriparatide. Now moving into the next question. A G2P1 delivered a preterm baby at 36 weeks, and this baby was in NICU. And the baby was given expressed breast milk, but the baby did not survive. Now, what is the drugs which can be used to reduce the engorgement and pain of the lactating breast? So what are we going to do? Now we need to inhibit the secretion of prolactin. How are we going to do that? There is dopamine. This dopamine, it acts as a physiological antagonist of prolactin. So we can give dopamine agonist. What are the dopamine agonists which are given? There are two dopamine agonists which can be given, which is bromocriptine and cabergoline. Bromocriptine is an old generation and cabergoline is the latest newer generation dopamine agonist. And what about the D2 selectivity? The D2 selectivity is less for bromocriptine and it is more for cabergoline. And potency also, it is less for bromocriptine and more for cabergoline. And half-life, it is up to 6 hours. And for cabergoline, it is up to 60 hours. Therefore, the dosing is going to change. This has to be given BD. And whereas cabergoline, it can be given twice weekly. Okay. And hence also, efficacy is more for cabergoline, tolerability is more for cabergoline, nausea is less. It is just the opposite. And use in prolactinoma, this is more preferred. And tumor shrinkage also, this is more preferred. Prolactin secreting tumors also, cabergoline is more preferred. So what is the dopamine agonist which you are going to give to reduce the prolactin secretion here? It is cabergoline. Is there any other dopamine agonist which is there in the question? You have pramipexole. This is also a dopamine agonist, but it is used in Parkinsonism. And what is sumatriptan? It is a drug of choice for migraine. Clear? So now we will go into the next question. Now, before moving into what is this? What does this ADR represent? It is libido reticularis. What is the most common drug causing? Amantadine. Amantadine is also used in Parkinsonism. Why have I put it here? Because bromocriptine can also cause libido reticularis, but the chances are less when compared to that of amantadine. But please remember, this can also has the capacity to cause libido reticularis. Now moving to the next question. A patient is diagnosed with type 2 DM and he develops bloating and unexplained diarrhea shortly after the initiation of an oral hypoglycemic therapy, and which drug is the most likely cause. So, as I said, I have already told, I have given you a table for DM. I'm repeating the same table everywhere where a DM question comes, if you can note. So, among this, there are two groups of drugs which causes GI disturbance a lot. One is metformin. Okay, metformin, it causes GI upset a lot. There is one more drug, which is alpha glucosidase inhibitors, which is acarbose and miglytol. And what is the difference? This alpha glucosidase inhibitor is mostly associated with flatulence. Flatulence will be the key word if they are asking. Okay, if that is not there, if just a GI upset is presented, then what will be your answer? Your answer is going to be metformin. Okay, do not forget. And what about the other group of drugs which they have given? They have given a DPP4 inhibitor. DPP4 inhibitor can cause pancreatitis. That is also in a very rare situation. And what is glimepiride? Glimepiride is a sulfonylurea, and this has highest chance of causing hypoglycemia. And pioglitazone is a TZD, that is thiazolidinones, okay? And this has highest chance to cause weight gain, okay? So please remember the area of all the drugs, right? Now moving into the next question. A leprosy patient was on MDR therapy. For therapy, he develops progressive reddish brown to black skin discoloration over several months. Which drug is responsible? So there are in TB, we saw a drug, tuberculosis, is going to change the color of the urine. What is that? That is rifampicin. Same way in leprosy, this is going to cause skin discoloration. What drug is that? It is clofazimine. Okay. So what is the drug therapy for the leprosy? We are going to use three drug regime. It is rifampicin, dapsone, and clofazimine. Rifampicin is 600, dapsone is 100, and clofazimine is 300 once a month supervised and 50 for daily. You can leave this clofazimine in paucibacillary leprosy and you can cut short the duration to 6 months. Okay. So when dealing with leprosy, of course, you need to learn about the type 1 and type 2 lepra reaction. Here, the rule of 5 is important. What is that? Type 1 lepra reaction is type 4 delayed hypersensitivity. So 4 plus 1 is 5. And type 2 lepra reaction is type 3 hypersensitivity. 3 plus 2 is 5. Okay, so do not confuse about the type of lepra reaction. And what do you give for type 1? In type 1, steroids forms the mainstay of treatment. Other than that, you can give clofazimine. Whereas for type 2, your thalidomide comes into picture. Thalidomide can be used only for type 2 lepra reaction along with steroids and clofazimide. Okay. So now moving to our next question. A patient is a known case of diabetes and she is showing microalbuminuria on urine analysis. Renal function test are normal. Which of the following drugs is not useful in the prevention of the progression of renal damage? We already saw about SGLT2 inhibitor. Am I right? What did we see? It decreases the hyperfiltration. How does it do? By reducing the sodium delivery to the macula densa, if you remember. And hence, it is going to help patients to prevent the renal damage. So SGLT2 inhibitors are of course given. And what about finerenone? Finerenone is a mineralocorticoid antagonist we already saw. This can also be used in the prevention of renal failure because it inhibits the fibrosis and inflammation. And what about angiotensin receptor blockers? The ARBs, what is it going to do? It is going to cause efferent arteriolar vasodilation, and hence the glomerular filtration pressure is declined and the glomerular filtration and the GFR rate is going to be maintained. This is all because of one single thing, which is efferent arteriolar vasodilation. So this can also be used. And what is the one which is not useful? It is this diuretic, which is a thiazide diuretic, hydrochlorothiazide. So this is the answer. Now moving into the next question. This is also a very familiar question. We have seen this frequently. Which hypoglycemic drug increases the risk of UTI? It is also an SGLT2 inhibitor. Why? SGLT2 not only inhibits the reabsorption of sodium, it also inhibits the reabsorption of glucose. So when it inhibits the reabsorption of glucose, more of glucose will be there in the renal tubules, and this is going to attract microbes and it is going to cause UTI. Where is this situated? It is situated in the proximal tubule of the kidney. So among this, which is the SGLT2 inhibitor? It is dapagliflozin. Again, I have put the same table if you want to revise it. Okay. Now, a patient with pulmonary aspergillosis was treated with voriconazole. Okay, which is false about voriconazole. So this voriconazole is a drug which follows mixed order kinetics similar to phenytoin. What is mixed order? That means, as I said, in lower doses, it follows first order. And when you increase the dose, it follows zero order kinetics. So in this kind of thing, what is necessary? You need to monitor the blood levels. So TDM is needed for this. Okay. And this is better observed in empty stomach. And in order to reach a higher blood level fast, it is given as a loading dose. And also, voriconazole is metabolized by CYP3A4 and CYP2C19 enzymes. So, whatever drugs is going to inhibit this metabolism or enhance this metabolism, you have to be very careful because it is going to alter the drug level of voriconazole. So with this knowledge about voriconazole, we will look at the option. It should be taken on the empty stomach too. Just now we said it should be taken on an empty stomach for quicker absorption. It needs TDM, yes, because it follows mixed order kinetics. It needs loading dose, of course, yes. It should not be administered with pyranxanomide. No, there is no such concept. Why are they giving? Because if they have given, it should not be co-administered with rifampicin, then this option becomes right. Why? Rifampicin is an enzyme inducer. It is going to induce voriconazole. So the effect is going to get reduced. Okay. So this option becomes right if pyranxanomide is replaced with the tuberculous drug, which is rifampicin. So the false option here is option C. So now moving into the next question. A patient presents with a cough, that is, which is producing sputum. Okay. So which of the following statement is true about the drug that could be prescribed? So what do you give for cough? See, for dry cough, you give antitussives. Whereas for productive cough, you give mucolytics. What are the antitussives and mucolytics available? C. Bromhexin, ambroxol, and acetylcysteine are all mucolytic. The antitussive which is available are dextromethorphan and codeine. So this should be used for dry cough, and this should be used for cough with sputum. That is, for productive cough, you need to use this. So now let us see what they have given. Codeine is a potent drug and quickly relieves the symptoms. No, because it is an antitussive. Here it is a productive cough. Bromhexin, yes, we can give bromhexin. But it also states and dextromethorphan. No, dextromethorphan is used as an antitussive only. Both it should not be given. So it is no. Dextromethorphan alone, as it does not have an additive potential. No, you shouldn't use dextromethorphan. Okay, because it is a productive cough. So what is the right answer? Bromohexane should be used as it liquefies the sputum. So this is the true option here. So the correct answer is option D. Now moving into the next question. A term neonate develops severe hypoxemia within hours of birth, and there is right to left shunting. Through what? Through patent to the ductus arteriosus. And this is with elevated pulmonary artery pressure. What is this there? The pulmonary artery pressure is elevated. And the other thing they have told is there is no structural congenital heart disease. And now, what agent will you use to reduce the pulmonary vascular resistance? So, what happens to the pulmonary vascular resistance after birth? Usually, the pulmonary vascular resistance after the birth decreases. In this case, what is happening? It is increased. Since it is increased, it is causing right to left shunting through the ductus arteriosus. And since there is left shunting, what is happening? The pulmonary artery pressure is rising. So what is the condition here? It is persistent pulmonary hypertension of newborn. So what do we need to do? We need to give a drug which decreases the pulmonary artery pressure alone without significantly affecting the systemic blood pressure. And what drug is that? It is NO. Nitric oxide can be given. So how does nitric oxide work? It increases the cyclic GMP and it causes vasodilation. Now one more question may arise. Why should I do that? If I close this ductus arteriosus, it will not go to the left side of the heart and hence the pulmonary pressure will decrease. No, don't do this mistake. Why? If you close this ductus arteriosus now, it will lead to right heart failure. So you shouldn't do that. Once you correct the pulmonary artery pressure, automatically the ductus arteriosus will close by itself. So for persistent pulmonary hypertension of the newborn, the drug to be used is nitric oxide, that via inhalational route. Clear? So the answer to this is we should not give. And the first step is nitrous oxide. This is no, okay. This is not. This is no. And this is nitric oxide. So what are the drugs which is given to close and open the PDA? This is an extra pearl we are going to learn. To close the PDA, what drugs we can give? We can give indomethacin. Or we can give ibuprofen, which are NSAIDs, which decreases the prostaglandin. And to open the prostaglandin, to open the PDA, we are going to increase the prostaglandin. PGE1 analog we are going to give, which is alprostadil. Okay, so what is the correct answer here? It is inhaled nitric oxide. Why does nitroglycerin should not be given? Because it also acts on the systemic arteries also. So nitroglycerin, it should not be given. And bosentan, it is used in, it is an endothelial receptor antagonist, which is used in pulmonary hypertension. It is not given in a newborn. Now moving to the next question. A 45-year-old patient, he presents with enterococcal endocarditis and he is allergic to penicillin. Which drug should we prefer? So please note, in enterococcus, the drug of choice is ampicillin, which is a penicillin family. When the patient is allergic to penicillin, then you have to shift to vancomycin. If he is resistant to vancomycin, go for linezolid and daptomycin. Okay, so this vancomycin drug, it has other advantages also. What is it? It covers MRSA also. It covers enterococci. And orally, vancomycin is used for where we already saw Clostridium difficile infection. And the classic ADR with vancomycin is Redman syndrome. Okay, so in penicillin allergy patients, what drug you can use? You can go for vancomycin. And how does this vancomycin act? Normally, there is going to be cross-linking between the peptide chains of the bacteria. And penicillin, it is going to inhibit the transpeptidases enzyme. What is vancomycin going to do? This vancomycin, it goes and binds to the terminal D-ala. Usually, the terminal D-ala, it will get cut off, and the previous D-ala, it gets connected to the neighboring adjacent L-lysine residue. Since this D-ala is not cut off, and since vancomycin binds to it, this also blocks the, vancomycin also blocks the cross-linking. But the mechanism of action between two is different, but the end result is the same. Both are cell wall synthesis inhibitors. Okay. Now coming to the next question. A patient with treatment-resistant schizophrenia is started on clozapine. What is clozapine? Clozapine is an atypical antipsychotic. So they are asking, which is the life-threatening adverse effect which necessitates regular hematological monitoring during the therapy? So the answer is already there in the question. It is hematological monitoring. Among this, which is a hematological feature, it is platelet. So clozapine is prone to cause agranulocytosis. Now, what is this other areas which is associated with clozapine? So I said clozapine, it can cause agranulocytosis. In addition to that, it can be cardiotoxic also. It can be neurotoxic also. And it can also cause weight gain. Okay, so these are the other adverse effects which is seen with clozapine. So the classic association question they usually ask is, clozapine is known to cause agranulocytosis. Olanzapine is weight gain. And risperidone increases the prolactin levels in the body. And ziprasidone, can you remember? We saw this drug under the drug which increases the QT interval. It causes QT prolongation. Okay, so these are the most classic associated areas with atypical antipsychotic. Now moving to the next question. A patient underwent hysterectomy and was given morphine in the post-op period and for pain. Now she presents with respiratory depression and pinpoint pupil. So what is happening? Opioid poisoning has occurred. So what are they asking? The drug used to treat this condition. We already saw what is the antidote for opioid poisoning. It is naloxone. What about the other option? Pethidine, it should not be given. This is also going to act as an agonist only. And what is buprenorphine? Buprenorphine is a partial agonist. Where it should be given? It should be given in case of withdrawal. When the withdrawal symptoms are there in addiction, that is why buprenorphine is going to act. And even if you get the option naltrexone also, please don't select, because it's the drug which is given by a oral route, and this is also used to prevent the relapse. Okay, so the correct option here is naloxone. And what are the features of opioid poisoning? The main feature is pinpoint pupil. The other thing is respiratory depression. And what other depression it can cause? It can also cause CNS depression. Okay, right. So now the next question. A renal transplant patient is receiving long-term cyclosporin and he develops cholestatic liver injury. Impairment of which transporter is responsible for this cyclosporin-induced cholestasis? This is a very direct question. See, cyclosporin is an immunosuppressant. It acts as a calcineurin inhibitor. What does this cyclosporin do? It causes dysfunction of MDR1, multi-drug resistant 1. That is, it is a P-glycoprotein. And since this is inhibited, so what happens? There will be reduced excretion of the bile constituents into the bile, and there's going to be stagnation of the bile, impaired bile flow, and hence cholestasis is going to occur. And hence the answer here is, it is MDR1. It is a very direct question, okay? It is an MDR1. Please remember, it is not MRP1, it is MDR1. Okay. So the other things you need to remember about calcineurin is that it can cause nephrotoxicity, and it can also cause gingival hyperplasia, and it undergoes metabolism by cytochrome 3A4. So this cyclosporin, how does it work? The cyclosporin and tacrolimus both are calcineurin inhibitors. Both that, for example, cyclosporin it binds to cyclophilin, whereas tacrolimus binds to FKBP2 and BP12, and both inhibits calcineurin. And this calcineurin, when it is inhibited, the NF80 will not get dephosphorylated, and there won't be interleukins which are generated. Whereas sirolimus is a mTOR inhibitor. What it does, it also binds to FKBP2, but instead of inhibiting calcineurin, it inhibits one more thing which is called as mTOR. And what is this mTOR inhibition going to do? It prevents the progression of the cell cycle from G1 phase to S phase. And hence, the cytokine production is, especially the interleukin-2 production, is reduced. So this is the major mechanism behind cyclosporin. Remember, cyclosporin can cause nephrotoxicity. Okay. Now coming to the next drug. Thalidomide embryopathy is mediated through multiple molecular mechanism, which is not considered as a major mechanism responsible for the teratogenic effect. So as I said, I told you we will see about thalidomide detailing. So there are two mechanisms. One mechanism is thalidomide having an immunomodulatory action. How is it doing this immunomodulation? Because it inhibits the production of IL-2, IL-4, and IL-5. Whereas the thalidomide's mechanism by which it causes the phocomelia is different. How does it doing? It is causing more of reactive oxygen species, as I already said. And it is causing inhibition of angiogenesis. And the most important is it binds to the cereblon protein. What is cereblon protein? This cereblon protein is one of the ubiquitin ligase complex. And when this binds, it is going to inhibit the abnormal degradation of the developmental protein. And this is a new mechanism by which thalidomide is going to cause is going to cause the developmental defects, that is binding to the cereblon protein. So among this, which is not considered as a metabolism for teratogenic effect, of course, reaction of ROS, generation of ROS is considered, inhibition of angiogenesis is considered, binding to cereblon protein is considered, but inhibition of IL-2, of course, it is an action, but it is more concerned with the immunosuppressive action. It is not concerned with the teratogenic action. Clear? So this is about thalidomide. Now coming to our next question. A patient in emergency has the following lab parameters. creatinine of 1.5 and BUN of 45. The chest X-ray is shown and culture only rhinovirus for isolated. What is the best treatment of choice in this patient? So since rhinovirus is only is isolated, don't consider that there is no bacterial infection. There are chances because the chest X-ray is showing signs of pneumonia, if you can see. Okay, so this is mostly a case of CAP. What is CAP? It is community-associated pneumonia. So what is the most common organism which is associated with community-associated pneumonia? It is pneumococcus. For atypical pneumonia, it is mycoplasma or Legionella. And for hospital or ventilator-associated pneumonia, it is Pseudomonas or MRSA. How do you treat CAP? It depends upon which patient you are treating. If it is an outpatient, if the infection is very mild, you can go for amoxicillin, a penicillin, and a macrolide. If he is hospitalized, you need to go for ceftriaxone and azithromycin. And in case of ICU patients, you need to go for beta-lactam and a macrolide. And hence the option here is ceftriaxone and azithromycin. Now moving into the next question. An anti-diabetic drug is causing a decrease in HbA1c by increasing the GIP and GLP and decreasing the glucagon. It also causes reduction in both three. So I told you the same tabular column. Which drug reduces both? It is a DPP4 inhibitor, which is also called as gliptins. Among this option, is there any gliptin present? Yes. Allogliptin. Okay, so this is the answer, which is option C. We have discussed more questions in the same pattern before. Okay, right. Now moving into the next question. A patient with HER2 positive metastatic breast cancer is developed progression despite trastuzumab-based therapy. Which tyrosine kinase inhibitor targets the HER2? So, tyrosine kinase inhibitor, what are the tyrosine kinase inhibitors available in this? Again, I'm going to show you the same table. Here, the patient has breast cancer and he has already received the MAPS. Now he is going to receive a small molecule tyrosine kinase inhibitor. And what are the two tyrosine kinase inhibitors available? It is lapatinib and tucatinib. Let us see whether it is available in the option. Yes, option A, which is lapatinib. It is the right answer. Why not aglutinib? Aglutinib is mainly used for colorectal carcinoma. It is not used for breast carcinoma. Hence the answer here is lapatinib. Now moving into our next question. A child has developed regression, stereotypic hand movements, seizures, and autism, and the diagnosis of Rett syndrome is made. Please note, even if they have not given this Rett syndrome, how will you diagnose it? The major clue is stereotypic hand movements. This is the major pathognomic sign of Rett syndrome. What is the recently approved drug? The recently approved drug, which is given for Rett syndrome, is trofinetide. You can also do by exclusion because all these drugs where it is given for migraine, the Jepens and the Ditens. Okay, so the answer is trofinetide. How is this trofinetide going to work? It is going to act as a IGF-1 analog, and it is said to promote the neuronal signaling. Okay, so the mechanism is still unclear, but they say it improves the neuronal signaling. So the drug which is used for the Rett syndrome is trofinetide, which is a IGF analog. So now coming to our next question. A patient is treated for major depression and he develops persistent painful penile erection, priapism. Whereas we saw this yesterday, we also saw this yesterday in scorpion sting. Do you remember? And what is the antidote we gave for scorpion sting? We gave prazosin here. Okay. So just leave this aside. Now we will come back to the question. So which antidepressant is associated with this priapism due to alpha-1 blockade? Again, I'm giving you a list. So among this, trazodone is the antidepressant which causes this priapism. Okay. So this trazodone, it is a 5-HT2 antagonist. In addition, it also causes alpha blocking action also, which is responsible for the development of priapism. So this is a significant area which is not associated with any other antidepressant. Please note it. And now coming to the next question. A patient with diabetes and COPD has developed post-operative urinary retention. Okay. So this urinary retention question, it has been asked in the previous meet. Okay. So what are the drugs which is used for urinary retention? So for not to understand that, you must know the pharmacology of the urinary bladder. See, in the bladder muscle, okay, that is mostly in the trigone of the bladder, you have two receptors, M3 receptors and beta-3 receptors. So, contraction, what does the M3 receptor do? Stimulation of this beta-3 receptors, it causes relaxation of this bladder trigone. Okay, and whereas stimulation of the M3 receptor is going to produce contraction of this muscle. Okay, and you also have alpha-1 receptor, which is situated in the neck of the bladder, which is near the area where prostate is also situated. Now, what are the drugs which are available? You have a beta-3 agonist. This beta-3 agonist is called as mirabegron. And where it is used, since it is causing relaxation, it is used for urinary incontinence. Okay. In M3, you have an antagonist and also an agonist. What is the agonist? M3 agonist is betanacol. Where it is used? It is used in post-operative paralytic ileus and also in post-operative urinary retention it is used. And you also have a M3 antagonist, which is oxybutynin, flavoxate, darifenacin. All these, what is it going to do? M3 agonist, it is going to cause contraction. So M3 antagonist will cause relaxation. So it has the same use as beta-3 agonist. It is used in urinary incontinence. Now you have alpha-1 receptor. As I said, contraction of this alpha-1 receptor, it is going to stimulation of the alpha-1 receptor is going to cause contraction of the neck of the bladder. And hence, you have an alpha-1 antagonist, which is tamsulosin, which is given for prostate, benign prostatic hyperplasia, the urinary retention, which is caused by BPH, it can be relieved only when you're giving an alpha-1 antagonist, which is tamsulosin. Clear? So this is about the pharmacology of the urinary bladder. Do not forget this. Now, the question is, post-operative urinary retention, which drugs can be used for the treatment? So the drug which is used is betanacol. Where is tamsulosin used? BPH, urinary retention, it is used. Terazosin also same. And methacholine, it was used for the diagnosis of asthma. Now it is not used nowadays. Now coming to the next question. A patient is having acute bronchial asthma and he is receiving high dose of salbutamol. She develops tremors and palpitation, which is not typically associated with salbutamol therapy. We saw yesterday, fine tremors and sinus tachycardia can be seen with salbutamol therapy. And what is the other two things? It is hypokalemia and hyperglycemia. Okay, do not forget these two. So what is the wrong answer here? It is hypoglycemia. Okay. Now moving into the next question. A 3-year-old chronic smoker, he has failed with multiple failed quit attempts. He seeks therapy for smoking cessation. Which of the following agent has the highest long-term abstinence rate in comparative clinical trials? So, this nicotine, this can be used during the withdrawal phase as a replacement therapy only. Okay, it cannot be used for abstinence, please remember. This too can be used for abstinence, the varenicline and bupropion. Among this, varenicline has the highest efficacy. It has shown highest efficacy in improving the abstinence rate. So that is what is highlighted here. And how is this varenicline going to act? As I said, it acts as the partial agonist at nicotinic receptors. What type? Alpha 4 beta 2 subtype of nicotinic receptors. And it also causes a mild dopamine stimulation also. And hence, this is going to decrease the nicotine craving. And it is going to decrease the reward from smoking also. Okay, so this is the highest efficacy for developing abstinence from smoking it is varenicline. Now coming to the next question. A patient with primary open-angle glaucoma is prescribed a topical drug which lowers the intraocular pressure by reducing the aqueous humor production through alpha-2 receptor stimulation. So which of the drug is most likely to be prescribed? So we must know about the drugs which is used in the treatment of glaucoma. 1 minute. So, coming back, what is the drug of choice for open-angle glaucoma? The drug of choice for open-angle glaucoma is a prostaglandin analog, like latanoprost. How is this going to work? It is going to increase the uveoscleral outflow. The next drug is beta blockers, like timolol, betoxolol. How is it going to work? It is going to decrease the production of aqueous humor. An alpha-2 agonist, how this is also going to decrease the production of aqueous humor. Under this only, drugs such as apraclonidin, brimonidin is going to come. Okay. In addition to decreasing the aqueous humor production, it can also have a minor increase in the outflow also, especially the trabecular outflow. Okay. And carbonic anhydrase inhibitor, you have acetylazamide and doxylamide. Doxylamide is given topically. How does it work? This also decreases the production. And Rho kinase inhibitors, phosphodil, netasudil. How is this going to work? It is going to degrade the trabecular meshwork, trabecular matrix, and hence it increases the trabecular outflow. These are the major drugs which is used for glaucoma. I left one which is myotics, which is not preferred nowadays. Okay. So among this, which is the alpha-2 agonist which is used? It is apraclonidin and brimonidin. So the answer here is option A, which is apraclonidin. Now moving into the next question. A 58-year-old man, he develops exertional retrosternal chest pain which is relieved by rest, and he is prescribed a sublingual nitroglycerin. By which mechanism nitrates improve the symptoms in classic stable angina? This is the important line. By which mechanism it is improving the symptoms? That means it is decreasing the pain. Okay. So this nitroglycerin, how does it act? This nitroglycerin, it releases nitric oxide and this stimulates guanyl cyclase, which converts the GTP into cyclic GMP. And this cyclic GMP helps in the dephosphorylation of the myosin light chain kinase, and hence it causes vasodilation. Okay, and this vasodilation is going to decrease the preload. It can also decrease the afterload also. But the major mechanism by which nitrate works is by decreasing the preload. And it is only via this, it is going to provide symptomatic relief. So what is the option here? It also causes vasodilation, but the major mechanism by which it is decreasing is reduction in the preload. Clear? Now moving into the next question. A patient with hypertensive emergency is treated with intravenous sodium nitroprusside. The vasodilatory effect is mediated by activation of which intracellular pathway? So they are asking the mechanism of action of sodium nitroprusside. So sodium nitroprusside, it comes under the family of mixed vasodilator. That is, if the primary site of action is both arterioles and also the veins. So how is it going to act? Sodium nitroprusside, also like it releases nitric oxide to cyclic GMP, which activates, please note, protein kinase, which decreases, which causes coagulation, and hence Am I audible?
Yeah, yes, ma'am.
Audible?
Yes, ma'am.
Okay. So I can continue, right?
Yes, ma'am.
Okay. Okay. Right. So coming back to the question, sorry for the inconvenience again. So we will come back to the question once again. So we are dealing with the signs of digoxin toxicity. So the gastrointestinal symptoms, as I said yesterday, are the earliest manifestations of toxicity. And the other toxicities I was telling was GI, and the next is visual disturbances, and the next is you're going to get arrhythmias. Please note, GI symptoms can occur even when the serum level of digoxin is within the normal range. And visual symptoms can occur even without arrhythmias. And also, the arrhythmias can also occur even without any significant visual disturbances. So, the options visual disturbances may occur in the absence of severe cardiac manifestation is true. And serum digoxin levels may not correlate with early toxicity. That is also true. And neurological symptoms can occur even without significant cardiovascular findings. That is also true. This means that all the toxicity features are not dependent on each other. Anything can occur at any time. But what is the last option? Option E. Digoxin commonly causes hypokalemia directly. No, this is the wrong option. Why? Because as you know, digoxin it works by inhibiting the sodium potassium ATPase. Okay, so when this sodium potassium ATPase is inhibited, the end result is going to be the intracellular calcium is going to rise. So where is digoxin going to bind in this sodium potassium ATPase? It is going to bind to the site exactly where potassium is going to bind. So when the potassium levels in the blood are low, what happens? More of digoxin goes and binds, and hence there is going to be toxicity. So what are we telling here? That hypokalemia, it can increase the chances of toxicity of digoxin because the sodium potassium ATPase, the potassium binding site will be free. So more digoxin will go and bind to it. That is why option E is wrong, because digoxin does not cause hypokalemia. Hypokalemia only causes digoxin toxicity. So I hope I'm clear with this. Now moving into the next question. A 64-year-old male, he has ejection fraction of 30%, and which drugs have no established role in improving the symptoms in chronic heart failure? We saw sacubitril, which is a neprilysin inhibitor, which comes under the RAS category. It can improve the outcome. Metoprolol, a beta blocker, it can improve the outcome. And nesiritide, which is a synthetic BNP analog, that can also increase the outcome. And which is the one odd man out here? It is trimetazidine. Why is trimetazidine not used? Because trimetazidine is used for angina. It is not used for heart failure. How is this trimetazidine is going to work? This trimetazidine is going to behave like a metabolic modulator. So how is it going to work? Normally, the cardiac cells, it uses fatty acid oxidation to derive its energy. But when it uses this, it needs more of ATP. And in angina, what happens? In angina, you need to decrease the energy use. So what the heart does, what this trimetazidine, it is going to redirect your heart from using fatty acid oxidation, and it promotes your heart towards using glucose oxidation, and hence the the usage of ATP will be reduced, and hence this acts as a metabolic modulator. So trimetazidine is a drug which is used in angina and it is used as a metabolic modulator. It has no role in heart failure. Now coming to our next question. This is also a patient of angina and he continues to have symptoms despite beta blocker therapy. A drug is added that reduces the intracellular calcium overload, and this drug works by inhibiting the late sodium channels, especially the late inward sodium channel. And what is the drug? So the drug is nothing but ranolazine. So now let us see what ranolazine is. So usually what happens is in ischemia, there is going to be activation of the late sodium channels. So when this late sodium channel is activated, what happens? There is going to be more of intracellular sodium, which is already accumulated. Since the intracellular sodium is more, the sodium calcium exchanger will not function. What is the function of sodium calcium exchanger? It is going to throw the sodium out and calcium in. This trisodium is going to come in only when the sodium levels are going to be low here. Already the sodium levels are high. So what happens? Sodium will not go out. And hence calcium will remain in. Since more calcium is there, what happens? This causes stiffening of the myocardium, and there is going to be diastolic tension which is going to happen. What ranolazine is going to do? This ranolazine is going to inhibit this late sodium channels so that the intracellular concentration of sodium is going to decrease. Since the intracellular sodium concentration is going to decrease, this is going to stimulate the sodium calcium exchanger, and sodium is going to come from inside. In exchange to that, calcium will go outside. And since calcium is gone outside, what happens? There's going to be reduced intracellular calcium and reduced diastolic tension, better relaxation, and better blood flow, and hence the angina is going to get reduced. So how does this ranolazine going to act? Ranolazine is going to block the late inward sodium channel. Trimetazidine, it is a metabolic modulator. We have one more drug which is ivabradine. What is ivabradine going to do? Ivabradine is going to act on your nodal cells, especially the SA node. The nodal action potential is different. It has three phases, phase 4, phase 0, and phase 3. The phase 4 is because of sodium inflow via the IF current, which is called as funny current. Phase 0 is because of calcium ions, and phase 3 is because of potassium effluxes. Now, what does this ivabradine do? This ivabradine, it inhibits this funny sodium channel. So what happens? The depolarization, it will occur very slowly, and hence the heart rate will decrease. Since ivabradine is given to patients in whom beta blockers is not working, then we need to add ivabradine to reduce the heart rate. Okay. So far we have seen 3 drugs which is used for heart failure, and which, please note, late inward sodium channel blocking is ranolazine. Funny current sodium channel blocking is ivabradine. Note the difference. And there was one more option which was given, which is nicorandil. What is nicorandil? Nicorandil is a potassium channel opener. And this nicorandil, it causes vasodilation because it is a potassium channel opener. Also, it has an additional effect of releasing NO. And that is why it holds its use in angina. Okay, so the potassium channel opener which is used in angina is nicorandil, right? And now coming to the next question. A 58-year-old male with recurrent gout attacks, he requires an antihypertensive therapy, which should be avoided. So you must know the antihypertensive that worsens gout. The antihypertensive which worsens gout or which causes hyperuricemia are the two most common diuretics, which is loop diuretic and thiazide diuretic. These two diuretics should be avoided in gout. And what has an uricosuric effect? That means losartan, which is an ARB. It can be safely used in gout. So let us see whether any loop or thiazide is in the answer. Yes, we have a loop diuretic hydrochlorothiazide. So the answer is option C. Now moving to the next question. A 27-year-old woman with chronic hypertension, he presents for pre-conception counseling. So that means pregnancy with hypertension is going to be the question. Which drug must be discontinued before consumption, before fetotoxicity? So you need to know the drugs which are safe in pregnancy, safe antihypertensive drugs in pregnancy. So the safest drugs are alpha methyl dopa, lebitalol, and nifedipine. So these drugs are safe in pregnancy. What should not be used? Lisinopril, which is an ACEI. It should not be used. Why? Because this can cause oligohydramnios and it can cause renal agenesis in the baby. And therefore, ACEIs or any drug which acting on RAS should be avoided. And the safest drugs are the other three options which is given here. Moving into the next. So this is very important. So this will be the last question of this discussion. So we are seeing here an anti-arrhythmic drug which prolongs the action potential duration and effective refractory period. That is, it is increasing the AP, it is increasing the ERP. How it is doing? By blocking the sodium channels. Not only it is doing that, it is also blocking the potassium channels also. So they are asking what anti-arrhythmic is this? So if you know, just now we saw how an action potential for a SA node looks like. Now we are going to see how the action potential for a cardiac cell looks like. So here you have around 5 phases, that is phase 4, 0, 1, 2, and 3. What is phase 4 happening? Phase 4 is the resting membrane potential, which is maintained as minus 90 millivolt. In phase 4, what is happening? From minus 90 millivolt, the voltage is shooting up to plus 30 millivolt. What does it mean? There is going to be influx of some positive ions. And what positive ions it is? It is sodium ions. Okay, so once it reaches plus 30 millivolt, there is a drop which you can see here. And what is this drop means? This drop means that the sodium channel is blocked now and there is going to be loss of some ions. What ion it is? It is potassium ions here. The loss of potassium ions is the reason for the phase 1 of action potential. After phase 1, there is a plateau phase which is phase 2. This means that this loss is compensated by an influx of another positive ion. That means the potassium is also lost, but this is compensated by the calcium entry. And that is the reason for phase 2. And the phase 3 represents rapid repolarization. This means that the calcium channel is closed here and the potassium channel is still open and the loss is happening. At last, it returns to the minus 90 millivolt and all ions are reset back. Why do you want to know this? Because this is the basics of antiarrhythmic drugs. So, as I said, the action potential of SA node we have previously discussed. Now, this action potential, it needs to be correlated with the ECG. So, if you see the QRS complex in the ECG, it represents the phase 0. This QRS complex, it mostly represents phase 0 of AP. And the QT interval, this represents phase 0, 1, 2, and 3 of AP. And the T wave mostly corresponds to the phase 3 of AP. These two are very important. So any drug which is going to decrease the phase 4 by blocking the sodium channel, it is going to increase what? It is going to increase the QRS. And any drug which is going to block the potassium channel, because potassium channel only is going to act in the phase 3, it is going to cause QT prolongation, which is responsible for toxa D pointers development. Okay, so these 2 points you need to remember. So the antiarrhythmic drugs are classified as class 1A, 1B, 1C. So there are 4 classes. One has subdivision of 3 classes, 1A, 1B, and 1C. And you have 2, 3, and 4. This 1A drug, it has sodium blocking property and potassium blocking property. 1B, it is a weak sodium, but it opens potassium. Please note this. And 1C, it has nothing to do with potassium. It opens sodium alone and it has a very strong blockade. And phase 2, I mean, the class 2 is beta blockers. Class 3 is potassium channel blockers. And class 4 is calcium channel blockers. So with this classification, can you tell me which drugs are going to prolong the QT interval? As I said, the drugs which blocks the potassium, that is class 1A and class 3, these two are going to block the potassium, and hence these 2 drugs have more of QT prolongation. Can you tell me which drug causes QRS prolongation? That is all the phase 1 drug. Since the phase 1B has a weak, the QRS prolongation is more with the 2 classes 1A and 1C. Okay, in our question, what they have seen, so this is about more in detail about 1A, 1B, and 1C. As I said, class 1A, it is going to be QRS and QT, and class 1C, it is a strong blockade. It is going to inhibit QRS only, and class 1B, it is a weak sodium blockade. So there is going to be no change at all. Since it opens the potassium channel, the QT is going to decrease. See the beauty of the drugs. Okay. So now what are they asking? They are asking which class is causing QT prolongation. That is, it is blocking the sodium as well as additional potassium channel blockade. So you need to look at the list of drugs which comes under class 1A. If you note, there is a drug which is called procainamide, which comes under class 1A. So the answer here is option B, which is procainamide. Okay. So when learning arrhythmics, please do not forget to learn about class 3 drug also, which is amiodarone. This amiodarone is a potassium channel blocker, and most of the questions surrounding amiodarone will be revolving around the ADR of amiodarone. This amiodarone, it can cause hypothyroidism. It can also cause hyper, but the most common is hypothyroidism. It can cause bluish discoloration of the skin, which is also called as Smurf syndrome. Okay, it causes pulmonary toxicity also. It causes corneal microdeposits. What does it mean? This means that this amiodarone, it has a very large volume of distribution, and that is why it is getting deposited in most of the tissues. So, with antiarrhythmics, we are finishing this live session. So, thank you everyone for your kind attention and all the best for your upcoming exams. Thank you.